I want to turn to our morning keynote and invite those speakers up to the stage. Dr. Ken Thorpe, chair of the Partnership to Fight Chronic Disease, Jason Burke, vice president of 3M, and John Molina, the chief financial officer of Molina Healthcare Incorporated. Let's give them a round of applause. Ken, you lead a national coalition. You've been engaged in health policy for a number of years. You now lead the health policy team at Emory University. You muck around in DC from time to time. Tell us how you think this time in our national conversation is similar or different from other periods of time in the national health policy conversation.
Well, I think it's, first of all, thanks for having me. And good morning, everybody. That's not a Southern good morning. Good morning. Come on now. I think it's very similar in the sense that we're still trying to debate the role of the federal government and the private sector on the financing side of insurance and how best to roll health insurance out for the uninsured. So that's something that's been around for 50 or 60 years. And we're still battling those demons. And we still haven't figured out exactly what the right mix is of public, private, federal, state responsibilities, individual responsibilities, and so on. I think what's different, though, is the fact that the health discussion is much broader than just insurance. There's a whole set of bipartisan discussions going on in Washington that are very new that focus on really four sets of issues around prevention, delivery system innovations, things that really affect all of us, not just the uninsured. The physician payment reform that was passed, MACRA, which will fundamentally change how healthcare providers are paid, moving away from fee-for-service to alternative payment models. Medicare, in a major move covering the diabetes prevention program, which will migrate into Medicare Advantage plans in the private sector. To really focus on the key driver of rising healthcare costs, which is the growth in the prevalence of chronic disease. Issues around care coordination. Medicare is having a major debate about how to bring care coordination into traditional fee-for-service Medicare, which will also have, I think, a spillover effect into what states are doing and what the private sector is doing. And some really interesting pilots that CMS is doing in terms of value-based insurance design. You know, recognizing the fact that 86% of what is spent on healthcare is linked to chronically ill patients. So the focus in Washington, which is on premiums and out-of-pocket costs, I mean, I think a lot of people recognize that you're not going to drive somebody with 6 chronic conditions through a $10,000 deductible because it doesn't make any sense. So the value-based movement is a pilot that allows health plans to select among 9 different chronic conditions and either reduce or eliminate cost sharing as long as patients are following clinical treatment protocols for their medications, their physician visits, and so on. So that is a major transformation that's going on in healthcare that doesn't get a lot of attention. It's bipartisan. That is new. The financing discussion that goes on, which is largely a budget issue. It's not a health policy discussion. It's really a numbers issue about how many people get covered, what are the deficit impacts, is really sort of budget-driven, not health policy-driven. These other things I've been talking about, the bipartisan efforts, which I think are transformational, really are bipartisan. And that, to me, that's the new part of the health policy discussion.
So, John, let me ask a perspective question. I think Molina Healthcare has elevated its position amongst the pantheon of health plans, particularly in the last decade, and particularly after the implementation of the Affordable Care Act. We had a dinner last night with some folks, and I said, as I said here, that Molina has also elevated its profile in terms of speaking out in support of the Affordable Care Act, really with no other comparable health plan voice speaking as candidly and as actively. One of the participants, and I asked this table last night why that might be the case, and one of the speakers who happened to be with the health plan said it was because other health plans were craven, was his word. I was shocked, candidly. I thought that came from somebody else, and but it wasn't. I thought that represented a real candid comment about where the other health plans are on this. Did the health insurance industry let itself down by not more actively advocating for the ACA since its passage in 2010? So now we're at a point where we're kind of playing defense for those that see it as progressive?
I think that a significant number of health insurers are afraid of the bully pulpit. And in this case, the emphasis is on bully, and it comes through a tweet. At Molina, my brother has really taken the lead on health policy, and he's not afraid. The ACA is a tremendous first step, but let's face it, it did not accomplish the goal to make things more affordable, and did not do anything to the supply of providers. Those were the two other things that I think needed to have happened, and given the bloody fights that went on after the passage and the way it was passed, no one else wanted to touch those other things, and now it's come back, I think, to hurt us. Fundamentally, it is the ACA's insurance reform. And what we need to do is move from the financing to the actual delivery of health care. And once Congress either does something to change the ACA or tries and fails, maybe we can put that to bed and focus on things that really affect patients, like, do I have a doctor I can go to? What is my deductible? Do I understand my benefits? I ask people all the time, have you looked at your healthcare policy that you get through your work, and do you understand all the ins and outs? And most people don't. And yet through the ACA, we did the greatest expansion for people who are at the lower income of the economic spectrum. And folks who are poor tend not to be as highly educated as the folks in this room, and yet we're saddling them with tremendous burdens as a consumer of healthcare. So we need to move beyond the rhetoric, beyond the politics, to actually start talking about how can we improve the system, not just how do we pay for it. Mm-hmm. Now, paying for it is really, really important. I'm not trying to minimize that. But in terms of what we need to do as a country, we need to get beyond that.
How do we, I think many folks, John, would agree with you that the Affordable Care Act was largely an insurance bill, that of the three North Stars towards which health policy might be oriented, either cost, quality, or access and coverage, and I merged those two. I know they're different, but I merged those two. That this was a bill largely focused on coverage and access. How do we get to a reorientation, or should we, away from access and coverage to cost or quality? Is it possible to do two of those three things? If I sort of, there's this, it's hard to do all three. But can we do two? And if we can only do one, are we still oriented towards the right North Star, or is it time to change?
Well, I think you have to, step one, you've got to get everyone some sort of coverage. We can't have people who are faced with bankruptcy because they get sick. We can't have people who have illusory coverage where it is basically the deductible is so high, the copayments are so high, they just have catastrophic coverage. Mm-hmm. So we've got to get the financing in place. Then we have to work on access. We are going to run into very, very shortly not enough providers. And nothing that I can see is being done to address that. Mm-hmm. There are the same number of residency slots now that there were probably 10, 20 years ago. That has to increase. We have to figure out how to use mid-level practitioners. We have to extend out and figure out how do we engage pharmacists, optometrists, home care workers in the healthcare continuum. Mm-hmm. Because as the population ages and consumes more healthcare services, just by the nature of their aging, without having more providers, we are going to have a system of haves and have-nots.
So Jason, 3M has quite an interesting and really long history in the background of healthcare, making it actually work through things like DRG, coding, methodology, et cetera. You now lead 3M's partnership with Google in trying to bring additional value to the overall healthcare system. Sitting from both the background and a little bit of it on the outside, Google's, for instance, not yet on the inside. You don't represent Google, but work closely with them. What are the big opportunities, i.e. the big challenges that you see in healthcare that you think will be most likely solved through outside disruption?
Yeah, so I would say, I mean, to John's point, one of the basic things that we have a problem with is defining what quality is. I mean, there's hundreds of standards out in the market, and frankly, nobody can compare themselves to anything because there's so many. I think that's where the federal legislation could help, is to add or create a standard risk adjustment methodology to basically say, here's how we're measuring quality and of care and cost, to align cost with it, so that everybody across the country, whether it's good or bad, has the ability to say, here's how I compare to others. I think that's a key issue that we have to address. I think that the exciting thing about healthcare is there is a tremendous amount of innovation happening. I mean, there's so many healthcare systems who are creating their own organizations to commercialize the value that they have. Intermountain Health, Geisinger, Cleveland Clinic, all of those organizations are realizing they have value that they can go out and take to the market. And then you have the commercial side with people like Google, Amazon, Apple, just trying to think about it. I think that the opportunity for those companies and the investments that they're willing to make and the way they think about healthcare can be very good, and it will be very good. I will say that the challenge that they have had is because they struggle to really understand and know healthcare. You know, they all know data science well, they all know, you know, how to do machine learning and how to look at data, but healthcare information is very unique. It's not like financial data or other types of data. You have to really understand what it means before you can make decisions around it. But I think those organizations are going to help drive innovations around removing waste, which I think is a huge issue in healthcare right now. I think the problem is we don't really even know where the waste is happening to remove it. And I think that's going to be probably the first opportunity for us to really impact healthcare is really identifying how we can avoid costs or remove costs to improve care. And then also having the ability to move closer together as a healthcare community to collaborate together. And I think we're seeing that happening today. I mean, you're seeing the industry consolidate through acquisitions and partnerships, but more organizations, payers, providers, vendors are all now starting to say, we can't do this by ourselves. We have to do it together. And that's where I think some of the basic things in healthcare need to change. Like the simple things are how much money is being spent trying to figure out where patients' care is happening and connecting that patient's care together. I mean, we don't even have, you know, a universal patient ID that we can link patients together. And I think when we do those basic things, like creating that, the collaboration can happen, but I also still believe that we have to have healthy competition as well. Mm-hmm. But having both is going to help us drive that innovation.
So one of the I think benefits of a panel like this one, and really throughout the day, is we have sort of different blind men and women around the elephant trying to talk about this thing called healthcare. We all have expertise in our part of the elephant. The other interesting part is that you as speakers get to be the ambassador from your entire sector. So Jason, as the ambassador from the technology sector in this conversation, You mentioned that the technology community hasn't quite figured out healthcare. From the inside of healthcare, I think a lot of particularly providers would say, we've been hearing from the technology sector for 2 decades that they have all of the solutions. And and Google and Microsoft and some of the big players have all kind of struggled. And there are hundreds of startups and smaller firms that have struggled. Why is it that from where you sit, why is it that either technology as a sector hasn't figured out healthcare, or why is it that healthcare is so hard to figure out?
I would say because it's probably one of the most complicated markets in the world. I mean, it's not something that you can, like look at banking. You can go into banking and finance, and it is complicated, but the data that you see and use and create is pretty discrete. I mean, it's numbers are numbers, right? When you get into healthcare, organizations, for example, they call congestive heart failure CHF or COPD, or there's all these different nomenclatures around what we even call things, and then determining what that means in their organization, and at a physician level, what that means to the physician and then the patient. So I think that the move to with meaningful use to move to adopt electronic health records, I think was a great step for the country. But you look at those EHR companies, and I mean, how many physicians love their EHR, right? I mean,
I think 7.
Right, seven in the world probably, right? And so they're all, I've worked with all of them actually, and they're all trying to spend money to make those workflows better and to make that process better. But because of all of the different personalities you're dealing with and the different types of practices, you can't make one thing that solves everybody's problem. But I also would say that that's why I think we will see in the industry more consolidation, but I think we'll see more partnerships that are going to help fill those gaps, because organizations are realizing that there isn't a one-size-fits-all, right? And I think in the vendor community and the technology side, companies are realizing that they have to have partnerships to make this work, or they're going to fail.
So Ken, let me ask you to be the ambassador from the great state of Georgia. Since you live in Atlanta and work and teach at Emory, Secretary Tom Price, let me make a declarative statement about him that I believe is the case, and you tell me where I'm accurate or inaccurate and supplement it accordingly. He is an orthopedic physician in caricature and in actual practice. He believes in the centricity of the patient-physician relationship, doesn't like anything, getting in the way of that, comes up through the medical foundation or medical association leadership ranks. And a cynical view of that from a colleague who's here today would say that if he could just get balanced billing in Medicare, he might be fine. And he'd say success and walk away. That's a cynical view. Where is that collection of statements accurate, inaccurate? How would you supplement it?
Well, Secretary Price was my congressman for 17 years, so I know him pretty well. I think his thinking on healthcare has evolved since the time he was in the state legislature to where he is now. One of the things that I would hope that he would do is have a bigger role in the deliberations on what's going on in the Congress. As I think about it, we have this congressional discussion about lower premiums, different levels of cost sharing and so on. And it's going on in a vacuum without thinking about who we're trying to provide these services for, patients. And if you think about it, as I mentioned, 86% of the healthcare spend is on chronically ill patients. The type of patient that we're expanding coverage to is a hypertensive diabetic with bad cholesterol, back problems, COPD, and is depressed. Has multiple physicians, 10 to 15 medications. But that sort of profile of the patient, which I would hope the Secretary, and I know he's very patient-focused, would enter into the deliberations, is going on in a complete vacuum in terms of trying to make the budget numbers work. We don't want to lose too much coverage, and so on. So at some point, the discussion between a system reform that focuses on patients and makes the world easier for healthcare providers has got to happen. Yes, we need to have a financing discussion. We got to get people covered. They have to afford to get access to healthcare. But if you think about it, the clinical complexity of these patients means that the type of delivery system that we have, the payment algorithms, the need for integrating acute and post-acute care services has got to change. We have patients that have behavioral complications and cardiovascular disease that requires a different way of providing care coordination with health teams focusing on the patient. That's not happening today. So these two discussions have to come together. We have to have the health, the financing discussion come together with really reforming our delivery system and prevention system. I'll just throw out a statistic. I mean, one of the things that is not well known up there is that if you look at Medicare spending increases, 90% of the growth in per capita Medicare spending increases over the last 15 years is due to rising disease prevalence. It's not due to increases in what we spend per case treated, it's due to rising disease prevalence. Well, that issue on prevention has got to be center stage as part of the deliberation. So I would hope, given his focus on patients and physicians, that we can bring together these discussions and really do health reform that affects 330 million people, not just trying to get access to remaining uninsured, which we need to do, but we need to have a comprehensive discussion on really doing health sector reform, not just simply health insurance benefit design reform.
So John, as the CFO at Molina, let me ask kind of a question that I think the answer is probably both, but let me just sort of pose this and see if you can parse it out for me. As you think about the numbers at Molina and in terms of costs, Ken is talking about the importance of focusing on prevention and utilization management effectively and care coordination. I think HMOs, I think Medicaid plans have demonstrated much greater success at that empirically than some PPO commercial plans. When it comes to policy, should policy help support that aspect, utilization management, primary care, like I think the ACA does in part, or should it focus on broken economic markets? In other words, cost and price is still a major factor where there is market consolidation and market leverage, and there are no other large hospital systems or no other drugs to replace the Hep C diagnosis, or few drugs, or where plans and the payers effectively have little purchasing power or ability to affect the market. That is a policy area which the ACA does not address. Should this next round of federal policy discussion be more focused maybe on the primary care prevention and utilization management, or should it be a little more focused on fixing broken economics in healthcare?
I don't think you can have one without the other. One of the things that's very interesting, the discussion on higher disease burden and more prevalence of chronic diseases really does get back to the financing of care. And here's the thing that is just the disconnect. We're trying to provide financing and payment models that pay for quality. Unfortunately, for Medicaid and Medicare, the payment systems, the way that rates and premiums are calculated, it is 100% based on fee-for-service data. Mm-hmm. So you can have a health plan, you can have providers that save a lot of money by providing very high quality care. They're not economically incented. Mm-hmm. In fact, from a health plan standpoint, you're probably incented to generate more costs because you can throw on top of that a margin for profit and administration, et cetera. And it's almost gotten to the point where, in many aspects, healthcare financing is almost like a regulated utility back in the old days. So we have to figure out how providers can legitimately be reimbursed and paid for quality, how the risk transfer or risk adjustments based on the acuity of the members is calculated. Interesting thing is right now, under the ACA, we transfer approximately 25% of our premiums, which in 2017 will start at about $4 billion. So we're going to transfer $1 billion to our competitors because theoretically they have sicker members than we do. But what's taken into account is not the acuity of the members, but it's how high the premium is. So you've got all of these issues that go against the policy of providing high quality, comprehensive care. In terms of the system delivery, I think we're going to be driven more and more to integrated delivery systems like a Kaiser, a Geisinger, a Cleveland Clinic, or for those providers who want to remain independent, we've got to create tight networks of virtually integrated delivery systems. Because if you look at the outcomes of those types of delivery systems, they tend to be better than wide dispersed groups of independent 2 and 3 doctor practices who are loosely affiliated with hospitals.
I got to tell you, I do think Molina has demonstrated not just its sort of confidence and courage of its convictions, but I think has been way out in front on trying to have a proactive care coordination strategy for its sickest members, to use data in thoughtful ways.
Thank you.
Well, thank you for doing it. But yet, when I listen to some of the SEC calls from providers that are publicly traded, I hear about providers saying we need to drive up our fee-for-service revenue in order to meet performance. This clinically integrated network, or excuse me, an increasingly integrated provider plan framework, I guess I'm wondering, do you see the providers at Molina that are employed by Molina, the primary care providers, is that a strategic advantage for Molina as a health plan? And is that something that you think probably should be built out more broadly as we move into this next phase of reform?
We do see it as a strategic advantage. It's much easier for a provider to be able to focus on, in our case, a single payer, and understand the rules and the requirements, as opposed to trying to figure out how to manage through 15, 16, 17 different sets of rules, because that's what they have to do in order to keep their practice open outside of an integrated system. So we are going to expand, but we're also expanding our definition of a provider. If you look at patients who are covered both by Medicaid and Medicare, the dual eligibles, people who have 5 or 6 conditions, an awful lot of their care isn't medical per se. We provide an awful lot of services for people to stay in their homes. So we have to make sure that they have food, that their homes are clean, that they can bathe and dress. These are social services, not medical services, but done right, it keeps people out of a nursing home and saves a lot of money. So now, the provider that people see on a daily basis may not be their primary care doctor, may not be their specialist, it may be the person who comes to their home for 3 or 4 hours a day that helps them maneuver through the day and keeps them healthy. I think the other thing that was mentioned earlier is the question about data and healthcare, and why haven't the technology companies sort of got it yet? In healthcare, but they have in a place like banking. Think of banking. There's a finite set of services. Everybody understands what a deposit means. Everybody understands what a bank balance is. Everybody understands what an ATM machine is. Healthcare is much, much different for a 9-year-old boy than a 90-year-old woman. But we sort of lump everything together and say, that's healthcare.
Yeah. So Jason, going back specifically to the work you guys are doing at 3M, we're going to hear from John Kitzhaber later today, the former governor of Oregon, and he's I just think the world of him and listening to him speak. One of the arguments he'll make is we talk about medical loss ratio as the amount of money that we spend on the delivery of care, and that's perhaps a misnomer. It is a misnomer, but that's what it's called. We should have a social loss ratio as well. In other words, an investment in those non-medical services that support health. But we don't have a code for an air conditioner to help in extreme heat. We don't have a code for making sure people have clean water in their home. 3M's working on things related to that back end and quality. Can the technology sector keep up with the kind of stuff that John Molina is speaking about and John Kitzhaber will talk about? I mean, is the technology community thinking about air conditioners and codes to support that, or are they thinking about flying cars and stuff that we read about from Uber?
I would say both. I mean, they obviously want to have flying cars, but
I want to have a flying car.
yeah, but I would say that that's one of the interesting things working with Google in the last year is that they truly have an interest in changing the health of people. And they believe that they can do that through collection of information and data to be able to learn more about each of us, which is good and bad, right? There's definitely a downside to that, or a risk. But the goal with our collaboration is really to do that. So how can we look at information beyond just what's happening in the hospital or happening in the clinic or happening on the payer side that can impact that person so that we're proactively looking at the factors associated with the problems with their health. Because to be honest, most of them are happening outside of healthcare. I mean, they're most factors associated with people's health is what they eat, how they exercise, all of the basic things. And I think we'll see some innovations around that. I do believe that everything's driven by money, right? I mean, that's our life, right? And so the challenge is that in a fee-for-service model, the incentives aren't there on any side to change the behaviors. And I think that's what we're trying to do is how do we change the whole system's behaviors to be able to take accountability and ownership and free up the barriers that we have so that patients want to partner with their healthcare provider. I mean, how many people love to go to the doctor or to the dentist, and most people don't, not because they don't like them. I mean, it could be painful, right? But because they know they're going to have to pay something. They know that they're going to get really bad news if they go. Or, a lot of people tell me they're afraid that it's going to be you got to come back 10 more times before I can help you, and that's a lot of that's because of there's the incentive for the healthcare delivery system is come back, and we'll work with you. Versus, and clinicians just want to treat the patient. I mean, they would love to get out of the whole, how do I code things, how do I document things? They want to keep people healthy, but if we remove those barriers for both the patient and the physician, and we started capturing that information, we would start seeing a change in the way people think about their health, and people would be more proactive and more willing to reach out to ask for help. And physicians and nurses and the clinicians would have more freedom to be able to be more proactive in helping those people.
Yeah.
So I think technology is definitely going to move and drive change and access to more information. But I think that the whole healthcare system has to evolve to be able to allow that to move faster.
Ken, we have been talking about the need to move faster. We've been talking about the need to move to value and quality for a long time. If it were easy, it would have been done already. How does this current federal health reform conversation support or inhibit that? What are your thoughts on what we know so far, and could change in any minute, to be the next version of the American Health Care Act?
Well, again, as I mentioned, I think there's really two movements going on in Washington. The first movement in terms of trying to repeal and come up with some form of replacement for the Affordable Care Act is one movement, and that's a budget activity. That's a set of budget numbers, trying to make sure you don't have as much erosion of coverage as you can, but it doesn't fundamentally get at any of these issues we've been talking about in terms of delivery system innovations, slowing the growth in healthcare costs. In fact, I'd argue with their focus solely on premiums and the resulting increase in out-of-pocket costs, it could potentially be very detrimental to some of the things we've been talking about. On the other hand, there's a whole bunch of other activities that really aren't getting a whole lot of attention that are going on in Medicare. And my hope is on having some real thought leadership on Medicare, because Medicare can drive changes in the private sector as well. And some of the things that are going on there are discussions on giving Medicare Advantage plans more flexibility in how they use their rebates, not to reduce cost sharing and provide supplemental health benefits, but to expand them into social services. We have a lot of evidence that shows that these community health teams that work with patients, that integrate social services to manage them, save money, and they produce better outcomes. So changing some of the rules on flexibility with MA plans could start to change the way that other types of commercial plans do business. As I mentioned, changes in the design of health insurance benefits to recognize that having a uniform deductible and cost-sharing structure when you got all the money linked to multiple patients with multiple chronic illness doesn't make a whole lot of sense. There's some good pilots going on in Medicare on that. Integrating the diabetes prevention program into the Medicare benefit structure, a program that saves money, reduces the incidence of diabetes and hypertension. All of these things that are going on sort of behind the closed door have the potential, if there's some real thought leadership at CMS and HHS, to move us towards some of these transformational changes that we're talking about. Because if we get this sort of embedded into what the Aetnas and Humanas and Blue Cross plans and Molina's already there, but some of the bigger national players do, we can make some of these transformations. And at the end of the day, in terms of how people get their health care, these are fundamentally more important issues that affects everybody. So I'm hopeful that that we keep this momentum towards moving towards alternative payment models and migrating away from fee-for-service. We need to get away from silo-based health care and recognize the fact that we need to integrate across the silos to provide better care for patients. And you only do that by changing the incentives. I mean, we have the healthcare system that we incent to have. We incent to have a fragmented, silo-based, non-integrated healthcare system because of the fee-for-service payment rules. Well, if you change the economic incentives, you change the way that the healthcare services are prevented and delivered. So all of those really important things that are going on in a very much of a bipartisan effort, which I would hope that we'd sort of would have started there to get some trust among Republicans and Democrats to have a broader discussion on financing. There's a lot of common ground up there that are really transformational that are going on that if we can just accelerate it and move away from a pilot mentality into an implementation mentality, I think are very promising. So I'm the eternal optimist.
So John, at the risk of, I just want to make sure I put a really fine point on this because at the risk of sounding gratuitous, because I'm not trying to be, but I think that there's safety in numbers, and yet there were not a lot of people, not a lot of organizations out advocating for the ACA. I think that the House Republicans have voted 60 plus times to repeal the ACA, yet now I think there's common acceptance as a result of advocacy efforts like Molina's and others that things like the pre-existing guaranteed issue ought to stay, I think that's generally accepted now by all parties in DC. Yet, let's say the current AHCA passes, despite whatever efforts might be made. What is so wrong? If I'm a Republican member of Congress, what is so wrong with saying a state like California, the Medi-Cal system, ought to be able to live within a fixed trend line? We're going to give you a 3% growth every year, maybe fix that to population, so as population grows, you can also grow. That's a central element of the bill, that there's some per capita cap or some block grant cap in Medicaid. Advocates have said, supporters, progressive advocates have said that's not acceptable because that would ultimately take money out of the system. But if I'm a fiscal conservative, it seems like the healthcare system, the largest part of our economy, ought to be able to figure out how to live within the rate of inflation. What do you say to that?
I think it sounds theoretically nice until you get to the next recession, and your block grant, which was based on unemployment of X, and unemployment goes up to X plus 50%.
Yeah.
I think that, excuse me, it doesn't hold necessarily. It might work if you pick the right rate of inflation, but they don't. And so the gap between what is needed and what is available is going to get too large. It's going to get larger over time. Mm-hmm. Because again, fundamentally, it's based on a fee-for-service mentality where providers all along the spectrum have an incentive to do more. And changing that mentality is going to be difficult. When you go to your lawyer, unless it's on a contingency fee, the more the attorney bills, the more you pay them. They've got an incentive. When you go to your plumber, the more the plumber does for you, the more you're going to pay him. And so now we're asking an entire healthcare system to say it's not about how much you do, it's about what the results are. Now that's the right way to go, but it's going to take people a while to get there. I also think that there are other ways to accomplish savings, bending the cost curve, et cetera, that don't involve per capita spends or block grants. And I think that, as was discussed earlier, the way you do it is you don't start the discussion based on the financing. You start the discussion based on what healthcare we're trying to achieve and work back from there. Anytime you put the financing first, you box yourself in.
So I'll give you all one elevator ride commentary to end, and I need a few minutes. You can see we just have a few minutes left. Jason, here in 30 seconds or so, what advice would you give to our audience of relatively senior folks, but from across the diversity of perspectives within healthcare? What advice would you give to them in terms of leading their organizations through this time of transition?
I would say it's critical for all the healthcare community to collaborate together to create models that are going to define better ways to practice and deliver care and engage patients. I don't believe that we're going to get a massive federal change that's going to change the whole thing. I think it has to start at a local level, a state level, even on the private side, to build models to prove that it will work. And so I would just encourage everybody to reach out to the organizations. You look at the retail groups, and there are competitive factors there, but realize that if there is true collaboration, it will benefit everybody throughout the system.
Ken, same question. What advice to the community about how to lead during a time of transition?
Well, I would sort of agree with that. I would focus on evidence-based models, best practice models that we know work. And we have lots of them out there in terms of, why does Geisinger work the way that they do? Well, they work the way they do because they have team-based care, integrated care under one roof. And there are ways of replicating that even in a community-based setting. So there are good models of how to deliver care to clinically complex patients that you can adopt community-wide. Looking at these prevention programs are another important component to prevent the growth in chronic disease. recognizing at the community level, there are a whole bunch of things that you can do that affect health, whether it's on parks and recreation and other things that really do affect health and longevity. There are a variety of non-healthcare issues that communities can collaborate on together. So I think I would focus on the things that are really important in terms of the health of patients. And most of the things we've been talking about are really not partisan issues. They deal with preventing disease, they deal with better engagement of families and patients. These are things that we can work on as coalitions together. And the Washington folks can continue to have their arguments on the financing. But in the meantime, there are a lot of things that we can agree on that really will fundamentally affect the health of patients in your communities.
Great. John, last word, advice?
I would echo these two gentlemen, and I would say don't be afraid to experiment, and don't be afraid to speak up. The folks in this room know more about healthcare policy than any congressperson, any congressional staffer, anybody in Sacramento. Don't let them define the dialogue. Healthcare is too important.
Let's give them a round of applause.